Our next speaker is Richard Lewis, MD, FAAN. Dr. Lewis is a professor of neurology, director of EMG Laboratory, and co-director of Neuromuscular Clinic at Cedars-Sinai, very well-respected facility here in the Los Angeles area. He is board certified in neurology, electrodiagnostic, and psychiatric medicine. He's a director of the GBS CIDP Foundation International Center of Excellence and the CMTA Center of Excellence. Dr. Lewis.
So thank you very much, and Dominic, thank you again for asking me to speak to you today. This is the third year that I've done this. So as a disclosure, I'll just tell you a story. I gave a couple talks at the recent neurology meetings in Washington, D.C. They were courses, and they were 2 days in a row. One was on CIDP, and one was on EMG aspects of demyelination. And so I get my comments back from the audience, and they say, "Wonderful talk, Dr. Lewis, but don't use the same jokes in two talks in 2 different days." So I say that because I've given this talk very similar last year. So some of the same slides and some of the same jokes are in there. I'm old, I only have 3 jokes, and I use them all the time. The other part before I speak, when I walked in today and I took a picture of it, was a poster from the Neuropathy Action Foundation talking about how this is a disease that more people have than no one knows about. 200 million people. It's a very apropos point. And I want to take time to suggest to you, really support these organizations, because it's time that that people do know about this. And the people who need to know about it are people in Congress who are funding research. Next week I go to Quebec City for a meeting of the Peripheral Neuropathy Society, a group of about 600 of us who are investigating peripheral nerve disease either in basic science or clinically. And these are people who are dedicated to understanding the disorders that you all are interested in, otherwise you wouldn't be here. But I would like that meeting to be 7,000 scientists and clinicians working on this disease. And the problem is there's not enough money in the system to support all those researchers. We need funds, NIH funds, other funds to do that, and the way to do that is to get to your Congress people through organizations like the Neuropathy Action Foundation. So that's my little pitch for today, but I mean it very clearly, I'm very involved in the Peripheral Nerve Society, and I'm hoping that we actually work closer with the patient organizations, including the NAF. So, Dr. Beydoun stole a little bit of my thunder here, which is fine, because I want to give us time to answer questions, have a time for you to ask questions and me to try to answer them. So we're going to talk a little bit in a similar way to what Dr. Beydoun did at the beginning of his talk about what is it that we're trying to do when we evaluate someone with neuropathy, but I'm going to take a slightly different look at it and try to look at it from my point of view when you come to me and your point of view when you come to us. And I think what we're going to see is that we see things slightly differently, and we need to come together more. So I'm going to go through some of this relatively quickly. So when we ask you all those questions and you think we're badgering you with all kinds of specifics, what we're trying to do is understand certain aspects that will help us figure out why you have what you have, can we come up with a specific diagnosis, and most importantly, what can we do to help you? Believe it or not, that's really what we want to do, is help you. So one of the issues is, what's the nature of the disease? Did it come on suddenly? Is it chronic? Is it progressive? Is it relapsing? And then understand where your symptoms are and how they evolved. So if I see someone who had Guillain-Barré syndrome and has completely paralyzed, I really need to know how it all started. Okay, that's particularly true with something like CIDP, with all those variants that Dr. Beydoun talked about. So the other issue is, what are the symptoms? Are you numb? Do you have weakness? Do you have pain? And do you have some of those things that we call autonomic symptoms, perspiration? Are you perspiring? I have a patient recently who has been somewhat difficult to determine the cause of his problem, but he was complaining that he was having excessive sweating. So excessive sweating usually that's not from neuropathy. But what it turned out, he was excessively sweating in his trunk, but his hands and feet were dry. And so what he was doing was perspiring excessively where he could perspire to compensate for the areas that weren't perspiring. And that's a sign of neuropathy. Remember, we talked about this length-dependent stuff. This not sweating is an autonomic symptom of his hands and feet in the length-dependent fashion. And it was really the clue that he really does have a significant neuropathic disorder. So I showed this slide last year. Those of you who were here last year know that I'm old and have this reference from the 1960s, I think. Besides, it's always nice to see Paul Newman's face, particularly when he was younger. But besides that, I wanted to talk about the way we talk to each other. And that is, when you say you're numb, I will tell you that half the time after I push and try to pull it out and dissect it out, you're not talking about numbness, you're talking about weakness. For many people, the idea that my hands aren't working right means they're numb. But for me, I need to know whether there's a sensory problem or there's a motor problem, what Dr. Beydoun was getting at. So that's why I sometimes badger tell me what you mean by numbness. And frequently, for neurologists, numbness is equivalent to pins and needles sensation and tingling, what we call paresthesias. For many people, when they're talking about sensory numbness, means I don't feel anything. And then when I stab them with my pin, because I'm a sadist, we all have to have our pleasures somewhere. You'll be surprised that you feel the pin, and yet you say, but I don't feel it. And it's because you have altered sensation. And some of the sensory problems is excessive feeling, like light touch makes, how many of you have where your feet when you go into bed and the bed sheets touch your toes, it causes pain? That's an altered sensation, what we call allodynia. A normal sensation of light touch should either be tickling or light and feel normal, but for some people, because their nerves are messed up, it's causing pain. And so that's a sign of neuropathy. It's the same kind of sensory phenomena that might not be called numbness, but it's also part of the same spectrum of those disorders. And we'll get into a few more of these communication mismatches. So frequently, when you come, you feel your job is to tell me how bad this is. You really want me to be impressed about how miserable you are. And I empathize with you on that. And that is an understandable desire on your part. I'm, in some ways, more interested in what's going on that's doing this so that we can help you get past the misery part. So I'm really looking at, I need to understand how this evolved. Did it start in one foot and then go to the other foot a year later, which may be more of this mononeuropathy multiplex disorder that Dr. Beydoun talked about? Or did it start in the toes and creep up to the ankles, and then when it got in the mid-calves, the fingertips started getting numb? That length-dependent disorder, which is the common thing you see in many diabetics. When you come, you want me to get rid of this now. And I don't blame you. If I could get rid of it now, I promise you I would. The problem is it's just not that simple. I mean, it's really a matter of trial and error, trying to figure out first, get as specific as we can so we can hone in on the treatments, but also recognizing some treatments are going to give you side effects that don't work, that make you not want to take it. Some things aren't going to work, and it becomes a trial and error. There is just no specific recipe for this, unfortunately. The other thing that I've learned over the years, that the number one fear of anyone who comes in with neuropathy is, I'm not going to be able to walk. And it's frequently hidden. It's not, sometimes people are wise enough to ask me that question. I've now gotten wise enough to preempt them and tell them right up front, you are going to walk the rest of your life. That is true in 95% of people with neuropathy. Now, they may need braces, they may need canes, but they will be on their feet the rest of their life, unless they get hit by a truck, which I can't prevent. But it's not true for everyone, and one of the things we do is to look for those types of neuropathy that are potentially going to give severe problems to the point of needing wheelchairs, et cetera. So for the most part, most people who come, particularly with painful toes and feet, the prognosis is good for walking and for function. And that doesn't preclude the fact that there could be a lot of discomfort and pain and some functional limitations. So we need to talk about that. But when you go to the doctor, tell them your fears. Be upfront about it. I'm really scared that this is going to kill me, or this is going to put me in a wheelchair. And let them respond to that. Because most of the time, I think the answer is going to be better than your fantasy of what is going to happen to you. I even have more mismatches. So you want a cure? I know that a cure is not usually possible. Sometimes patients with CIDP, our studies show that about 15% of patients are cured. That is, if we use the cancer cure of being without symptoms, off medications for 5 years, we have about 11 to 15% of patients are cured, and another 20% seem to be in remission for less than 5 years, but they haven't gotten to the 5-year point. So we don't know how many of those 20% will stay in remission, but that's been the percentages when we've looked at our cases. So we look for cures, but realistically, many of our disorders we can't cure. And that's not just true for neuropathy, it's true for many. You don't cure hypertension, you don't really cure diabetes unless you get a pancreatic transplant, but we control them with medications, and that's good. Not perfect, but good. You want the pain to go away. And I know that many, and particularly with neuropathy pain, every once in a while I hit a home run. Most of the time I'm working towards hitting a double or a triple, getting that pain from a 7 out of 10 to a 2 or 3 out of 10. Discomfort but not misery. And we just need to be aware, and we need to work together so have realistic expectations. Because if you're expecting to completely go away, you're probably not going to like any of the treatments I offer you. If you're willing to accept the fact that I've gone from being miserable, not sleeping, to where it's just uncomfortable but not miserable, we have to call that at least a partial success. The other issue is when you come in and you're needing ankle-foot orthoses or braces, most of you want to get out of those, and I don't blame you. The problem is I know that the treatments are going to get rid of the mildest symptoms first and the most severe ones later if I'm going to be successful with those at all. So we need to keep those expectations. And when I start a treatment, the first thing I want to know, like IVIG, does it have any effect? So if I can get those shoulders that are a little weak to be completely strong, at least I know the IVIG is doing something. Then we can give it more time. But I give it 3 months, and if you don't show any signs of recovery of the mild muscles that are weak, then we're going to say it doesn't work. And unfortunately, IVIG gives everyone energy, and that doesn't mean it's treating the disease. IVIG treats, how many of you used to get gamma globulin shots when you were tired and weak? This is the older people in the audience, this would be what your family doc would have done 30 years ago. IVIG is just fancy gamma globulin. It's just concentrated gamma globulin with a specific portion of it. And immunoglobulins help energy. Probably not worth $10,000 a treatment to give you a little boost of energy. And your insurance companies are not going to be too excited about that. So we're looking to disease-related, can we make that disease better so you don't go into a wheelchair? Because unfortunately, CIDP is one of those diseases that can do that. But the good thing is we can treat it. And besides IVIG, we have a number of other treatments. The other bugaboo here is fatigue and weakness. So this is where the IVIG giving you energy gets confused as to be a disease treatment. Fatigue isn't weakness. Weakness for us as neurologists is if you hold your shoulders up, if I can push them down, you're weak. If you say, well, I was walking 3 miles and my legs got tired and I needed to sit down, that's a muscle fatigue, which is significant. But if you said I'm sleepy and I want to go to sleep and I'm tired, then that's a whole different kettle of fish. So we need to understand fatigue is a very complicated factor. What cancer fatigue is, if any of you have had chemo or any of that kind of stuff, you know what it does. It wipes you out. It really, and a lot of it has to do with chemical mediators in your blood system, chemokines. Think about the flu. Why should a virus make you feel wiped out, like you can't get out of bed? It's not because of the cough you have. It's because it activates chemokines and cytokines and all the things that Motrin is supposed to do. IVIG does treat some of those things, so it does help those things. So one of the things we do in the history is we look for other disorders. We need to know whether you have rheumatoid arthritis or diabetes or lupus, because some of those things are associated with neuropathy. A big one is family history. So if you had to name the top 10 disorders that cause neuropathy, diabetes is number 1 on the hit parade. Number 2 worldwide is leprosy, which most of you probably are not likely to have. The third one is what we call idiopathic, which means Dr. Beydoun and I are too stupid to figure it out. And the fourth one is probably inherited. That is, people genetically, and it's the most common inherited neurologic disorder, and probably the second most common inherited disorder outside of cystic fibrosis. So it's a very common disorder. And then toxics like chemotherapy and other things and some nutritional things are, and those are really the top 5. CIDP is not even in the top 5. But it's the one we can treat, which is why it's so important. So I'm going to move on a little fast. I think I told the same story last year. I'll tell it again. My wife, who's a psychologist, had to come with for an appointment with one of her patients for me to do an EMG study. And the first thing my wife said is, boy, you spend a lot of time with people's feet without buying shoes, which was the way she uses does feet. But the feet are very important. First of all, from a standpoint of complications of neuropathy, having foot ulcers, I don't have a pointer here. Yeah, I have to get, where's my mouse? Oh, here it is, okay. So here you go. So if having foot ulcers can lead to infections, bone infections, and amputations. So those of you who have neuropathy need to be very careful about the feet. Calluses are a big sign that there may be an issue. So you need to, and frequently people should either go to a podiatrist if you're having trouble cutting your own toenails, get a podiatrist to do it, but it's very important to watch your feet. Calluses say your feet are rubbing in the wrong way. The dryness of your feet from neuropathy is one of the predisposing factors to that. So we do use things like tuning forks, and you've all had us hit with a tuning fork and say, do you feel it or not? It's amazing how many people say they feel it when they're not. So I have them close their eyes, I buzz it so they hear the ringing, and then I stop it and put it on the foot, and they still say they feel it. And the reason is twofold. One is because your feet are already buzzing, and you can't tell what's external buzzing and internal buzzing. Second part is you want to impress me. You're hoping that to do this. So there's an element of wish. I want to feel it. So it's an interesting phenomenon. But sensory nerves are divided into large ones, which is the vibration and position sense. And the position sense of the toes tell us whether you're likely to have imbalance from your neuropathy, because balance is based on three things: your vision, your inner ear, so because if you have dizziness, you're not balanced, and whether you feel your feet on the floor. There are some other aspects to balance. So one of the things your doctor does is tell you to put your feet together and close your eyes, because if you take away one of those pieces, vision, you need both the vestibular system, your inner ears, and your feet to guide you. If your feet aren't doing well, you start feeling wobbly and can fall over. So that's what we call the Romberg test, but it's very helpful to know whether the sensory nerves are giving you trouble with your balance. So more of my sadistic nature comes out here. We hit you, and we stick you, and we scratch you, and we do all kinds of stuff to try to figure this out. It is all done for a reason. People with neuropathy usually have reduced reflexes or absent reflexes. People with that length-dependent type may only have it at the ankles. People with CIDP would lose them everywhere. People with genetic neuropathies frequently lose them everywhere, even though they're only weak in their ankles or in their hands. So there are clues that we get from all this. Scratching the bottom of the foot is to look for non-neuropathy stuff. So Babinski's sign, where the big toe goes up when we scratch the bottom of your foot, tells us the central nervous system is involved. So strokes will do that. Spinal cord compression will do that. And there are some people who have neuropathy and central nervous system problems. And when we see that, we think about things called myeloneuropathies, spinal cord and nerve. And the most common thing that does that is B12 deficiency. So we look very carefully for B12 deficiency when we see that combination of stuff. The other one that does this is actually copper deficiency. And people who've had gastric bypasses, if your doctor is not aware about copper deficiency causing this, that may be missed in the thing. You may get your B12 shots, but you're not getting your copper replacement because your stomach's not able to absorb it. Okay. Atrophy, I think Dr. Beydoun talked about. Some of the signs of motor weakness from neuropathy is loss of muscle tissue. And in your hands, if you've lost some of this muscle in between your thumb and your index finger, that's a sign that the ulnar nerve has been involved. In your feet, it may be a thinning of the muscles below the knee. That's signs that there's been nerve damage and the muscle has been lost. The other thing that can confuse the neurologist sometimes is when we try to test their strength and there's a little bit of shaking. Weakness to a neurologist is when there's a relatively consistent weakness from the beginning of the effort to the end of the effort. So sometimes we ask you to do things to try to get rid of that shaking, which again comes from sometimes anxiety, sometimes trying too hard. No one's blaming you, but it's just what we do. So speaking of sadism, we always have the EMG. And the EMG, I understand. And I can't tell you how many patients come to my EMG lab and say, I had it before, it was awful. This was the worst thing ever, don't do anything to me. And usually we kind of work it out. I say, just give it a try, and frequently we can kind of get past it. So it is uncomfortable. Anyone who says it's not uncomfortable is probably lying to themselves or to you, but it's not terribly uncomfortable for most people. Any electricians in the house? For them, it's impossible. They are the people who cannot, they look at the machine and they're screaming. And literally, you can put the prongs on and not stimulate, and they're jumping off the table. The mind is a wonderful thing, but past experience influences your current experience in tremendous ways. So, but in general, you know that our electrostimulus is in the thousandths of a second. You feel that little electricity jolt, but it goes away like that. So, and very rarely do you have any long-lasting, even minutes later, anything. And the needles are needles. Anyone says the needle doesn't prick is wrong. The needle's a needle. But no damage, it's totally safe, and most of us who've had it, and I've had it a number of times, you walk out of the room and you're feeling pretty good. You may have a little bit of red spots where the needle stuck you, and don't drink water because you'll be a fountain, but other than that, it's pretty safe. The reason we do it is because it really is a crucial way to understand what your nerves are doing. As Dr. Beydoun said, is it a problem with the loss of the wires or the axons, or is it a problem with the insulation of the myelin? And I apologize, I had some nice videos of nerve fibers, but it didn't work on this, and I didn't want to take up time doing that. But just the axons are the wires, myelin is the insulation. If you strip off the insulation, you change the conduction from going at 50 meters per second, so 50 or 60 meters per second. Think about it. If you're 6 feet tall, you're 2 meters long. Okay, so it's going up and down from head to toe 25 times in a second. And that's why I can say thumb flex, and it does it like that, because it goes that fast. If you strip off the myelin, and you do that in the peripheral nerves, and that would give you a demyelinating neuropathy, the conduction velocities can go to 20 meters per second, 10 meters per second, 5 meters per second. And at 5 meters per second, you're going to be weak from that slowing. At 20 meters per second, it's still going pretty fast, fast enough that you can still get that thumb to twitch almost instantaneously. And the strength will be okay because it's enough firing one after the other that the tetanic contraction of the muscle, the buildup of that muscle tension, will remain. So in a disorder like CMT1A, the most common inherited neuropathy, the conduction velocities are frequently 20 meters per second in every nerve of your body. But the only ones that are weak are the ones that lost the wires, which are down at below the knees and in the hands. And that's because the axon loss is really the key determinant of what makes you weak. The demyelination tells us what may be causing it, and if it's demyelination with inflammation, then it's CIDP, and we got treatments for you. So that's why we do it. It helps us distinguish between the types of neuropathy that you have. So here's a little bit of a list of the different neuropathies. And you can see that the axonal ones are more common, but they're less treatable in terms of treating the disease. The demyelinating ones are more common, more likely to be treatable. And the demyelinating ones, CIDP, can get very severe. But I have had many people with CIDP in wheelchairs and sometimes bedridden who've, with the right treatments, have jumped up and have been able to do full activities and are virtually normal. So it's a wonderful, when it works, and the treatments work 3/4 of the time, it's a very good disease to treat. So on the nerve conductions, we have certain ways we look at it, and then we talked about the 20 meters per second. There's a thing called conduction block, where your signal goes from it's working, and all of a sudden it just gets blocked. The wires remain intact, but the signal gets blocked. And in MMN, that's the key aspect of that disorder. And it's really a disorder of the node of Ranvier. which is these, now I'm lost here. But those little, you can see the little sausages there. The parts that are in between, that's the node of Ranvier. All the work of the nerve to get the signal happens in those little, where the arrows are, okay? So at MMN, the disease is attacking that little segment in there. In CIDP, that myelin is getting stripped off like you see in some of those other segments. So the needle part of the EMG is to look at the muscles. So the nerves tell us about the speed, gives us some idea of amplitude, tells us about the sensory nerves, but the needle tells us a bit of 10 minutes. I'm going to try to wind up pretty quick for you so that you can ask some questions. So the needle EMG tells us whether there's nerve damage by how many motor units are working. If half of them are working, then you've probably lost half of the nerve fibers to that muscle. But it also can tell us a little bit about chronicity and acuteness. So I'm going to go there. Nerve biopsies, I'm going to make it quick. Most of the time, they're not helpful. So if someone says, get your sural nerve biopsied, get another opinion by a neuropathy specialist like Dr. Beydoun or myself or Dr. Shea and Graves at UCLA, and we'll decide. There are some times when it's helpful, but actually most of the time it's really not going to give us the answer. And these are some of the things where nerve biopsy can be helpful. Vasculitis is an inflammation of the blood vessels and basically cause a little stroke of the nerve, and that can be treated. Amyloid neuropathy is an important one that needs to be treated. And sometimes the nerve biopsy is the only way to come up with the answer. So treatment, and I'll spend the last few minutes on this. This is a key because after a number of years practicing, it's really a big issue. You and your doc really need to work together on this. You need to know what his expectations for the treatment are, and he needs to know what your expectations are. So again, what we talked about, if your expectation is to get out of those braces, he needs to let you know that's not going to happen in the first few months. It may never happen, but what we're looking for is to stop the disease from progressing and make the muscles that are partially weak stronger. If we can see that in the first 3 months, we have the formula for success. And whether it eventually gets you out of the braces or not is a little hard to tell, because if the nerve fibers are destroyed enough, they're not going to get better. And so sometimes with the EMG, they can help you figure that out. So make sure that, and the doctor should actually work with you to work on, here are the things we're going to look for. I'm going to look at your shoulder muscles. I'm going to look at your hip muscles. I'm going to look at sensation in some way, so that you and the two of you know what you're doing. The other thing is, a lot of my patients, this is probably more in California than in Michigan, I'm not taking any medicine. All medicines are bad, and come up with another approach. And we need to come to grips with this a little bit. First of all, there are risks and there are side effects. If I give you a medicine, you're nauseated, and it really bothers you, you're not going to take it again. I guarantee you your nausea is going to go away. So it was a nice try, but it didn't work, and no harm done. You may have lost a few hours of nausea, which is, understandable. A risk is I give you the medicine and you die. And I take away the medicine, you're still dead. That's a big issue. And you need to know the risk. But risk and side effects are not the same thing. So make sure that you talk to your doctors about this. And I understand your fears. But you need to, because the right treatment at the right time is worth trying. The other thing is, I hear, I'm not going to tell you, but what about all those other things I can get at the natural health store? Well, in my mind, they're drugs too. They're just not FDA-approved drugs. And for the most part, they have less risks and less side effects, but not without risk and not without side effects. So some of this is a little paranoia that the government is doing something at the FDA to poison us. It's not true. So I think you really need to give these things a try. So we've talked about this. There's treating the disease and treating the symptoms. Treating the disease sometimes carries more risk than treating the symptoms. But the gain is we stop the disease from getting worse. The symptom is, usually it's pain, is how do we get, or cramps. It's important, but we may not want to take the same risks for that as compared to stopping a disease that can put you in a wheelchair. So I think I'm going to zip through this a little bit. Here are some of the neuropathies that are treatable. There are a lot of other neuropathies out there, but in general, we look for the ones that are common, that are treatable, and the ones that are potentially dangerous too. So some of the ones that are dangerous we cannot treat. If it's related to a cancer, it then depends on whether you can treat the cancer. So these are some of the things we look for. So on that note, I'm going to skip this because neuropathic pain medicines, there are a number of medicines that work, and it's really trial and error. But in general, the ones that work for nerve pain are medicines that were devised for seizures and medicines that are devised for depression. And the reason for that is because the neurotransmitters for all these things, pain, epilepsy, and depression, are very similar, and they all interact with each other. So the treatment of pain requires a number of things to go on. If you're not sleeping well, you're going to be in more pain. If you're in a lot of pain, you don't sleep. So you need to work on sleep and pain. And if you're not sleeping and you're in pain, you're going to be depressed. And if you say you're not depressed, you're not being honest with yourself, because it's hard to be miserable in pain and not be miserable in many other facets of your life. It feeds into each other. And if you're depressed, you're going to be in more pain. So you need to act on this in multiple fashions. So there are different ways we decide on which treatments we use. Narcotics and medical marijuana. Narcotics are said not to help neuropathic pain, but there are times when people use it and it can be helpful, and I've used some chronic narcotics in rare patients who've never escalated the dose, who allowed them to work and be very functional where without it they weren't. Marijuana, if it works, great, and it's something that you have to decide on. And then there are many other things. No question in my mind that things like meditation, yoga, and things that can kind of get your mind off yourself and may have some other effects on neurotransmitters are worth doing. I think it would be part of the process. I don't think these things work on this alone, but they certainly are helpful. And then there are interventional treatments, and these are where the pain centers tend to concentrate their efforts. Cramps, recent studies have shown this mexilatine is particularly good for cramps and may be worth trying. And I'm going to stop there. I just mention that we do have some clinics at Cedars working on some of this. There's a clinical trial for painful neuropathies that we are just up and running, looking at the different treatments. And on that note, I'll stop, and maybe we have a few minutes for questions. So thank you very much. There was one all the way back there. We're going to start in the back. Essential tremor. Essential tremor is a little out of the spectrum of our diseases here. It's really a central nervous system disorder. It comes from the basal ganglia of the brain. And the peripheral nerves are really not a factor in that. Saying that, there are people with neuropathy can get tremors, and there is a group of patients with CMT who frequently have tremors, so there is some association rarely. But essential tremor can be treated with medications. Of course, one of the better ones to treat is alcohol, but I'm not suggesting that you drink 8 times a day, but it's also a diagnostic thing. People with essential tremor, where they try to eat and their hands shake, if they have their sherry before their soup, they can eat their soup. So, but there are medications that are better for your liver than for that. Yes? Sure. So small fiber neuropathy is, I mentioned the small fibers, which are the pain sensation and temperature sensation fibers. So patients with small fiber neuropathy frequently have pain, and it's usually a burning pain, sometimes stabbing pain. And the problem is the EMG test doesn't show it up, because the nerve fibers that test are much larger than these. These fibers, the small fibers, when I said 50 meters per second for conduction, some of them are unmyelinated and conduct at 1 meter per second, and some of them are small myelinated fibers conducting at 2 to 3 meters per second, very slow, and they don't show up in the test. It's a bit controversial, small fiber neuropathy. Right now, probably the gold standard for determining small fiber neuropathy is the skin biopsy with looking at intraepidermal nerve fiber density. And if you don't have any nerve fibers in your skin, then you probably do have a small fiber neuropathy. If your biopsy shows that you have 4 instead of their lower limit of normal is 5, I don't really personally think that is necessarily interpretable from a clinical standpoint. Small fiber neuropathy has gotten messed up with fibromyalgia, and that relationship is one that is controversial and needs to be worked out. The key to it, most small fiber neuropathies are not, we don't have a specific cause. Diabetics, particularly pre-diabetics, frequently will have small fiber neuropathy. There's a so-called Sjogren's syndrome where small fiber neuropathy comes up. Occasionally amyloid can show up as a small fiber neuropathy. Most of them we're too stupid to figure out category, and the treatment is really treatment of the neuropathic pain. Yes, I'm sorry, I'll take that, and then I promise I'll get you. Yeah.
I had a
Mm-hmm.
I went 4 years without being diagnosed, and in a 4-year period, I saw 12 different doctors. What do you recommend for someone who is working with a doctor in the sense that either they're not sure what's going on, or what they're trying is not working, and it's continual, progressing and going back and forth? At what point do you say, you know what, thank you for your service, I'm going to look for someone else, or you go back to your primary, find another doctor that can assist you try to figure out what's going on?
So what I would say, certainly what we talk about with CIDP, I'll start with that and then I'll talk a little bit. With CIDP, if someone's given you a treatment, okay, I'm sorry. Treatment is, this gentleman has MMN and went a long time without diagnosis, saw 12 different doctors before Dr. Beydoun diagnosed him. What's the formula to when do you divorce a doctor for not coming up with the answer and go and get a second marriage? So there's no right answer to that. But in general, I would say, be honest with the doctor. This isn't working. Do you really, are we now at a point where you're trying different things but not really sure what you're doing? And would it be appropriate for me to see someone else? And who would that person be? So we, in CIDP, colleagues of mine and a number of us with the GBS CIDP Foundation Medical Advisory Board have been talking to patients about the fact that many patients with are being diagnosed with CIDP when they don't have it, and being on IVIG for many, many years. My longest is 15 years when they didn't have the disease. Treated their energy, but the disease was getting worse. and their disease, or the disease was, they never had the disease that was being treated for. If the treatments they're giving are not working, it's reasonable to get another opinion. And I would suggest going to a specialist in that type of disorder. So that's where Dr. Beydoun and I and colleagues at UCLA and other places, this is what I do. I do neuropathy every day, every week of the year when I'm not playing around. So I'm not saying that I'm perfect, and there are many times I get my colleagues to help me. So, but I would say if you're struggling with the disorder, with diagnosis, you may want to get a second opinion. With CIDP, you have the GBS Centers of Excellence. There are now about 20 of them around the world. We're one, UCLA is one. I don't know if Dr. Beydoun has done that, but he should. And there are a couple others in California, in San Francisco. Okay. There are more questions. I'll stick around for a little bit. How's that? And I promise you're first.
Thank you very much.